All right. TIA clinic. What the heck is a TIA clinic? First of all, what's a TIA? Transient ischemic attack. It's not necessarily a mini stroke. TIA is actually where a blocked artery occurs. You're about to have a stroke, which is permanent damage, but it goes away before it does. It's kind of overused because no one really knows what a TIA is because it goes away. It leaves no damage. So how do you define something that doesn't exist? So basically, we start this TIA clinic where people can come with any sort of symptoms whatsoever. That could be a TIA, pre-stroke, not a stroke, headache, carpal tunnel, it doesn't matter. You should be able to come to a center that can differentiate between this. And so what does that mean? It needs to be efficient, right? You're coming with any symptom, you want to be seen right away. So we're talking about coming to a center that has someone who knows what they're doing, can call anybody who needs you, like dietitian, physical therapy, speech therapy, occupational therapy, rehab, cardiology, vascular surgery, intervention. I mean, this is what a TIA clinic is. It's coordinating all these entities that you may need on an urgent basis for your symptoms that may be a TIA. So what did we have before we had this, right? So now we have this, right? It's not common. Like I said, we're trying to open that up in Tacoma. We're getting some resistance from the hospital. They can imagine, right? They like this stuff, but they're not very efficient, so they're kind of backing off on this. So my feeling is we need to start this because people want to come in and get urgently treated, evaluated by the proper specialists. So what used to happen, right? So what was the old way? The old way of doing things before this fancy schmancy TIA clinic? Well, you were discharged to the wilderness. So what does that mean? What does that graphically mean? Okay, so that's what it means. You think I'm being a little facetious, I am. But from the standpoint of you go to the hospital, you go to the emergency room, you have some ER physicians who know what they're doing. I'm not denying that, but they don't know stroke. They didn't get trained in stroke. They have their certification in terms of how to evaluate stroke. But what if you didn't have a stroke? What if you had a TIA and you're about to have a stroke? Do you need to be admitted for 2, 3, 4, 5 days with a normal symptom? Or you want to go home. I would want to go home, but you still need to be evaluated. So what happens? You get discharged to the wilderness. That's the old way. So what we're trying to do is we're trying to say what's new in stroke care. New in stroke care is going to a TIA clinic, which I'm going to help nationally try to make sure that we have certified TIA clinics so people just don't pop them up because they're trying to make as much money as they can. But actually certified TIA clinics where you go and get proper treatment front to beginning, front to end, fast, urgently, and effectively. So what is a vascular neurologist? What the heck is that? Is this just a fancy title? Yes, it is. But in fact, a stroke neurologist is someone who goes to specialized training to learn all about stroke in terms of beginning to end. I'm talking about beginning to end and how to coordinate everything on this table. How to coordinate between vascular surgery, cardiology, do you need intervention, do you not need intervention? Because here's the thing, you go to a back pain, you have back pain, do you go to a surgeon for your back pain? Why don't you go to a surgeon for back pain? Correct. But if you go to a surgeon for back pain, what is he going to want to do? Surgery. Now, I'm not saying all surgeons will do that, but they want to do surgery. They're good at that. They're not good at what happens if you don't get surgery. So they say, oh, you don't need surgery. Where do you go? Oh, you remember the wilderness, okay? You don't want to be in the wilderness. You want to be taken. But they don't send you necessarily to the chiropractic. Thank you for the heckling. Keep coming. Now, so the thing is, the vascular neurologist is basically a gatekeeper to where you need to go. Same thing when you have back pain. Where do you go? You go to the chiropractor, you go to the neurologist, you go to your primary care, you go to someone who knows about back pain so they can tell you, do you really need to have surgery? Do you not really need to have surgery? Same thing with vascular neurologist. You're going to go to a vascular neurologist. Do you need intervention? Do you not need intervention? If you have a blocked artery in your neck, do you go to the vascular surgeon? No, you don't. You may end up there, but you go through the system so people know, so they don't have intrinsic interest in your potential outcome. They have a potential interest in your outcome in terms of a human being, but not necessarily just of surgery. Okay? So all these things are coordinated in a TIA clinic. So this is what's new. This is what a vascular neurologist does. So here's the thing. Coumadin's been around a long time. We've proven that with a certain level, when you have a certain heart rhythm, you have a decreased risk of stroke. However, you got to make sure that you eat, green leafy vegetables in a certain amount, the equal amount. You get blood checks on a regular basis. If it gets too high, you have a bleed. If it gets too low, you have a stroke. That does not sound fun. It doesn't sound like a situation I would want to be in. So what did they come up with? Well, they've done a lot of research and a lot of money to come up with this brand new stuff. Now, I don't have any racing stripes on my back. I'm not getting paid by these companies. Pradaxa. Now, there's a lot of new things coming out, right, in terms of the problems with these drugs. New drugs don't necessarily mean better drugs, okay? They're not tested as thoroughly as the old drugs have been tested, so there's still potential complications that can occur. But the comparison is, do you want to be on something that you don't have to get checks, you don't have to worry about eating your spinach that day, or do you want to take the Coumadin? Now, right now, people are continuing to take the Coumadin because it's known. We know what the risk factors are. We know what happens if you take them. We know what happens if you don't take them. But if you take the Pradaxa, we're thinking that it's equal level, but we're learning every day about these new problems, heart attacks, excessive bleeding. So it may not be as good. Now, there's 2 other drugs that came on the market similar. So I'm just making you guys aware of the new stuff that's on the market in case you have something called atrial fibrillation, and you can have this conversation with your doc, who knows whether you should be on this medication or not. International ratio. So what it is, it's basically a ratio that they determine in the lab based on a standardized level. Somewhere between 1.8 and 2 is reasonable level of anticoagulation. If you get above 3, you have bleeding. If you get below 1.8 to 2, you have a stroke. So thank you very much. All right, something other cool toys. This is a cool toy. Looks kind of scary, like Frankenstein over here is going to stick you in there and do something to you. Well, that's kind of what it's like. So if you have a stroke, after you have the stroke, weakness, balance difficulty, speech problems, what do you do? Where do you go after that? Woo, no, it's not the wilderness. I'm going to piss off the rehab people in the back. You don't go to the wilderness. You go to rehab. You go to physical therapy. You go to speech therapy. You go to occupational therapy. Great. Then what? What happens is there's some new things down the pike coming. It's actually already been used for several years. This is called transcranial magnetic stimulation. They're actually been using it for depression, just like ECT therapy, where they kind of go to the brain with a big, huge electrical pulse. They're actually using magnetic fields now. They're using this for headaches. Now they're using it for strokes. So what you can do is you're applying a magnetic field, you actually induce activity or you inhibit activity and allow the problem side of the brain to act better. So this is a very cool treatment that's coming down the pike that's going to help people with stroke who do their physical therapy, who do their speech therapy, but then what? You can do repeated therapy over and over again, but you got to regrow some tissue. If we can't put stem cells in there, and we can't put you a new brain yet, maybe you can come out my TI clinic and we can use, no. So you use this transcranial magnetic stimulation device to regrow it. So this is coming down the pike very soon. So if you had a stroke even 10, 20, 30 years ago, you can still get better, and this is the kind of stuff we're going to be using to make you better. It has been used on animals for decades in terms of inducing electrical activity, and there's something called evoked potential response, which they've been using in EMG with people with motor problems and Lou Gehrig's disease and things like that. But they found that certain levels, certain frequencies, can either excite or inhibit the brain. In terms of who developed it, I think that's controversial. I don't want to name one person, leave someone out. I might get some litigation involved. But there's more than one company making this particular device. But in fact, who made this goes back years and years. Another new thing, which isn't so new, they've been around 2003, 2004, 2005, is stroke centers. Okay. Stroke centers is where, ideally, you're supposed to go to get the best care. You're supposed to go to get the best care because they have the highest level of people and toys and things and experience. But in fact, it's turned out to be something more or less, depending on your viewpoints. They have pathways. So you come in and they say, here's your name, here's your room. They have order sets. So you sign, here's your name, here's your room. They have stroke units. Here's your room. Here's your name. We have stroke teams. Hi, I'm on your stroke team. Quality reviews. I think we did a good job. Documentation. I'm going to write that I did a good job. Performance measures. I'm going to show everybody that I wrote down that I did a good job. The basic is the stroke centers was a new idea. Concept was excellent. Here's a few stroke centers outside Seattle region. There's 4, right? You see them, right? So if you live outside the outside Seattle region, don't go up to the Okanagan, hanging out at Nia Bay, Providence and Olympia, Southwest Medical Center, Cadillac, Sacred Heart. So what's around Seattle? This is much better. So you're in good hands, right? You have Tacoma General, St. Joseph's, Auburn Valley, Overlake, Evergreen, Northwest, Virginia Mason, Harborview, and Providence. You have all these people that give good stroke care, right? But if you remember that slide, what was missing from that slide? Experience. There's nothing on there that says you have to be good at what you do. You just have to document it, review it, and say that you did it. So there's different levels of stroke centers. So from my standpoint, stroke centers are a good start, but it's not the end game. And so when people go out there and they start advertising, we're a great stroke center, we're a stroke center, here's my billboard, here's my radio commercial, here's all my stuff. Do you have the experience? Right, I'm a vascular neurologist, I take care of stroke, right? I'm pretty good at it. I've been in a lot of training to do it. Go ask your hospital, do you have a vascular neurologist? How many of you think has one? How many of those on that screen have a vascular neurologist? Stroke fellowship trained vascular neurologist. Well, actually Harborview has one. Actually, they have a few. They've trained University of Washington, have several. I'm at Auburn. Evergreen has an intensivist who actually is very good stroke. One center I forgot, I apologize. I'm sure I'll get a call from Dr. Lukoski. Swedish Medical Center's on there, but now they're part of Providence, so I'll just include them in the list. Very few have the experience to take care of a stroke or TIA. They do the pathways, they got certified, but they don't necessarily have the highest level of experience. So you start at a low bar, let's raise the bar. So my feeling is what's new is stroke centers, what's coming down the pike is what we need to change to is higher level of experience. All right, this is more cool toys. I got some cool stuff. These things are basically aggrandized corkscrews that go into your brain and pull out a clot that's in an artery. Kind of reference size. I'm passing these around so you can kind of get a sense of the feel of these, what they look like. Kind of basically the same concept. There's these little wires that grab the clot and move around. Grabs the clot. Hope you guys aren't squeamish at all. This is kind of nice use stuff. And I washed them off before I handed them out. You know I'm kidding, right? Maybe. You don't know me. These are not used, the ones I'm handing out. And in fact, when you take a look at them, it's something you feel like you can go to Home Depot and make and kind of stick it in someone's artery and take it out. When in fact, these cost millions of dollars to put together. So I'm handing those out to kind of get a sense of what they look like and what they feel like to kind of take your clot out. So that's new. We're doing this interventional stuff. So why do we need this, interventional stuff, right? So we do what's called TPA. The reason TPA isn't on the list of new, because it's old. We've been doing this since 1996. Before that, this is not new stuff where we give what's called tissue plasminogen activator, which is a clot-busting medication you get when you come in within 3 hours. In fact, the world's doing 4.5 hours, and most stroke neurologists are doing 4.5 hours, but FDA says you can only do it 3 hours in the United States. In fact, we'll do it up to 4.5 hours. To give you this medication, if you show up with a clot, we give you the medication. But honestly, if you have a big enough clot, it's not going to dissolve it, right? It's like basically stroke is like plumbing, right? Take a hose. That's basically stroke. Okay, do you have collaterals? Do you have extra hose going out to your garden? Do you not? Is it kinked? So the problem is we need to go up there sometimes and take out this big clot. It's not just it's not just liquid plumber with the TPA. You got to do a roto-rooter basically sometimes, and that's what those devices are that I'm handing out around the room. Now, what is this map? It almost looks like something you get from World War II. These are the nuclear bomb sites, and this is the radiation zones. Basically, what this is a map of the United States, and the red is basically driving time within 60 minutes of coming to a stroke center, where you could get these pathways and TPA and things like that. Not necessarily intervention. There's a vast swath of the United States that you're not going to get there in time, right? You're just not going to get there in time. So are you out of luck? Should people just not live in Wyoming? I'm not sure I should ask that. Anybody from Wyoming? Wyoming's a great place, okay? So, but in terms of where can you go to actually get the treatment if you have an acute stroke, you can see that it's very concentrated in certain areas, and you really don't get the treatment you need potentially. Well, new stuff, right? So what's new? What would you do to kind of expand this to a point where people can get it? Do you go up to 4.5 hours for TPA, the clot-busting medication, for people who are on blood thinners? The answer is yes and no. And the yes is if you don't fall within a certain range of anticoagulation. So if you're on certain medications that are blood thinners like Lovenox or heparin or Coumadin or Pradaxa or things like that, you may not get the medication because you're already anticoagulated and you could bleed on this medication. If you're on aspirin, Flavix, things like that, yes, we do give the TPA. Now the thing is, there's still a caveat to that. Even if you're on those blood thinning medications, the heparin, the Coumadin, the Pradaxa, we still will go in there with the Roto-Rooter and take it out. You just won't be available for the intravenous. So still show up. Just because you have a stroke, and oh, I'm on Coumadin, I'm not going in, I'm just going to hang out here. No, you can still have treatment. You're going up there and roto-rootering it. We're doing this with what's called angiography. So you're actually looking at the site real time as you're going up with it. So you actually see where the clot is at all times. You go up there, you put the thing through the clot, you grab the clot, you start pulling it out. Most of these devices have little suction tubes on the end, so you grab the clot, suck, grab it, all this kind of stuff. But the second part of that question, if I interpret it correctly, yes. Once you get most of the clot out, what happens to the remainder that kind of sits there? Shower, right? So you kind of justify sacrificing the distal territory of your brain to save what's being supplied by the proximal segment. Yes, you're going to get clots going distal to that. Now, I guarantee down the pike, there's going to be even further sophisticated devices that are going to go through the clot, put out a little net, grab the clot, so anything that goes distally will be able to grab as well. I guarantee that's going to come down the pipe. And I think there's some studies actually going on with that right now. All right, so what can we do to kind of open up this map? So something called telestroke. The old way, very slow. You get dressed, you get in your car, hope you don't get a ticket, drive to the hospital. Sometime later, you get to the hospital and hope the patient is within the window of 3 hours from the time they started to the point that you're getting there to actually discuss this. So what's new? Lightning, fast, quick. So what's new? What's the new representation for that? That. Is that cool or what? And it's not just because my picture's on there. This is the new cool thing. It's telestroke. It's real-time HD video audio that can actually see you, treat you, interact with you, help with the examination when you are having a stroke. This allows for that map that you saw earlier with the red line that shows that Wyoming is basically out of the loop to come into the loop. Because now hospitals and those distributions can get this, to get the treatment, to get the expertise at the bedside within seconds. Let me give you an example. I was taking call at 2 certified stroke centers simultaneously on one night. This is a great story. I love the story. It was a great way of testing it. I got called for one hospital with a person who just had an acute stroke within the window, didn't have telestroke. So I get up, get dressed, get in my car, drive as fast as I can without hurting somebody or myself, get to the hospital, get into the hospital, get the history, look at the images, go in, talk to the patient, go find the family, talk to the family, come back out, get the report, come back in, tell the patient that they have a stroke. I can't show it to them because I don't have access to the imaging to bring them in to show the room, but they have a stroke. It's really bad, and you got 5 seconds to decide whether I'm going to give you medication or you're going to die. Now. That's not fun, okay? You're in a life and death situation, and this is what you're going to go through, not just from the doctor's perspective, but also from the patient's perspective mostly. That's not the best care, I think. So we gave TPA to this person who had the stroke. How long did it take from the time that I received the phone call to me actually pushing the TPA into this person to treat their stroke? Now, a good benchmark for the nation in terms of you showing up to a hospital and getting TPA, people will get on Channel 5 saying, we do this in 60 minutes. Awesome. We're so awesome. Listen to the 60 minutes. I did it in 52 minutes. So I wasn't just showing off, trying to delay things to make one thing look better than the other. It took me 52 minutes. I always thought that was pretty dang good. Okay? It's the same night. Believe it or not, I live equal distance between the two hospitals, believe it or not. Same night I got called for a TPA patient with stroke at the telestroke hospital. How long do you think it took for me to evaluate the patient, talk to the family, show them the image, after they got the image, and push the TPA? 15 minutes. We averaged 15 minutes for the first month and a half for every TPA patient using telestroke. This is so much better. This is urban, okay? These are urban hospitals, stroke centers. This is working so much better in the urban setting. Now, offline, because I'm going to get in trouble if I start the politics this time, or you can watch my talk 2 years ago where I really ticked off everybody, about where do you go? Where do you go if you have a stroke? That's a question people ask me. Where do you go if you have a stroke? My answer is, you go to the place that has the fastest, most efficient, effective, and experienced care. That's where you go for stroke, because that's where I'm going for stroke. That's where I want my family to go for stroke. I don't want to go to a place that has stroke just because they have a good billboard or a good advertising campaign. I want to go because I want to make sure I or my family is going to get better. And that's how I treat my patients. And anybody in here who knows me, there's a few people, know that that's exactly true. I'm not just paying lip service to that.
Come from 911, know that, have that information?
Do the medics know whether they know? Yes and no. The medics are very smart people because they're the front line. They're the triage because they ask me those questions too. Where should I take my father? Where should I take my mother, my sister? And I give them the exact same answer. Go to where you think you're going to get the best care, and I give them examples of how to get the best care. And then they have to make those decisions. So the EMTs are very savvy because they're the ones dropping the patients off at the front door about who's giving the best care. Now, there's some places that give really good donuts and really good coffee and really good break room, but in fact, they're going to take the people that they care about to the place that they know they're going to get the best care. And so, yeah, the EMTs do know. And in fact, I do a lecture circuit with the EMTs on a regular basis with regards to their care.
Is the AMA or any other organization doing more to train vascular neurologists?
There are certain tertiary centers that train vascular neurologists, but you can imagine they're so rare that these tertiary centers are going to hold on to these people. Hence, the University of Washington has trained almost all of their stroke neurologists that they have. So most centers across the nation are doing this. In terms of going private, very few people have the guts to leave their nice warm center where they're getting their salary to go and venture off and try to do something like this. So believe it or not, there's very few actually independent vascular neurologists out there because of this. So the centers will grab onto them because there's so few of them available. So in fact, the new entity is actually grabbing as many independent vascular neurologists as possible and bringing them together to cover as many places as possible using this technique. Because it's very hard to get more than one vascular neurologist in a room. It's not just because they don't like each other or because they have anti-polarizing effect from a magnetic field. There's just not very many of them. But we can use this, right? And like I was telling the gentleman earlier, at Auburn Medical Center, I have 7 people just like me covering Auburn Medical Center at all times. No? Some are in Utah, some are in Nevada, some are in California. So we can get these people to cover at different places all the time. And this is the new trend. So this is me in my office. There's actually a person in this room who's on this video, Miss Valerie Little from Good Samaritan Hospitals, best stroke coordinator that they have. I think it's the only one, so not I could tease her. She's great. So this is basically my office in Renton, that I'm able to do this, but I have a similar setup at home. Now, he was saying, kind of facetiously just calling it in. Well, literally, I am calling it in. But we're doing it very professionally, very efficiently, and with high expertise. And I'm able to show, if you can see on the right, I can actually show the family, the image on the right, to the family at the same time. That's why I can see the patient dropped off at the ER door by the EMTs and give them TPA within 15 minutes. Because everything can be done right there, on my end and their end. Because you saw the previous picture, right? That that was the other side of the story. Okay, why didn't I use this for the hospital? One hospital had telestroke, one did not. So the hospital that did have telestroke, I did do this from home and did it in 15 minutes. So, and the question is, would I, so what's the efficiency? So this is one person that we did at Auburn Medical Center. It's one of our first cases. We did her, what was it, 17 minutes? Somewhere around there. Yeah, 17 minutes from start to finish. When she was dropped off by the EMTs, EMTs called the ER, ready to go. We put a line in her arm to get the CT angiogram. CT, I was talking to the family as she was in CT. As she was wheeled back from the CT, I was reading the CT and CT angiogram, saw the clot, mixed the TPA, saw the patient, examined the patient, gave her the TPA. She was normal how long after? 20 minutes? Literally right in front of Valerie here, she became normal. She was plegic. She couldn't speak. She couldn't move. She was confused. Her eyes were off. There she is. She's with her dog now. That's afterwards. She's doing fantastic. This is what rapid, efficient, effective, and expertise care can do for you if you do it right. The trick that we did on top of this is another cool toy, which I didn't include here. It's ultrasound. Everybody's heard of the ultrasound of the neck. Everybody goes in, right? Goes to their cardiologist, their guinea pig, their dermatologist, 7-Eleven, and they get the carotid ultrasound. Most of those people stop here, right? They don't know that they have arteries past the head. What's the head? Why do they do that? Because a lot of people can do this. Make lots of money. Is that best patient care? No. You have arteries in your head. We say use the same ultrasound in your neck, on your brain, at the same time we're giving you TPA. That busts the clot 50% more than if you didn't use this fancy ultrasound. Now, I didn't include that in this one. Maybe I'll actually do a demonstration. Now, the next question is, would I do this, who would I do this on? Would I do this personally, right? It's one thing to do it professionally, right? It's another thing, would you send your family to do it? Would you use it on your friends? Would you use it on yourself? That's my dad. He showed up to Auburn Medical Center the same night I was on call, couldn't speak, couldn't move, completely confused. He had stopped his Coumadin just like any person's dad was just as ornery as everybody else's family, right? So he stopped doing what he was supposed to do, had a stroke from his atrial fibrillation. They called me. So what should I do? Should I call it in? Should I say he's family, I got to go somewhere else? He's got nowhere else to go. What did I just say about expertise? Where else is he supposed to go? He's got nowhere else to go. I've got to step it up. So I dialed in, saw him, examined him, put the CT scan, saw this huge clot. He was not going to do well if we didn't get that clot out of there. I gave him TPA by using the telemedicine system. I think I did it in 25 minutes with him. Yeah, it was pretty quick. And here he is, doing much better. It's fantastic. And I included his story in there. It was published in the I believe, the Kent Reporter. It was also published as one of the National Stroke Association's Faces of Stroke last year in May. It's also on their website as well, so I included that story. And Miss Millis's story is also, you can kind of get a sense of what this really does for patients. This is on a personal level. This isn't just me going up here and just spouting off of all this fancy stuff. This is me taking care of my own family, flesh and blood, and this is important to me. So I would advocate using this kind of stuff on anybody. It's so much better.
When you get an ambulance to your home or to somebody's home that you happen to be at, and there is a problem, not a stroke, and they say, no, you don't get to choose where you're going here.
She makes a good point. So she asked the question, so she makes a statement, which I'll comment on with regards to when an ambulance picks you up, you have no right to choose where you go. That's not true. You always have the right to choose where you go. However, you are correct that if you do not bring that up front, the new Senate bill with regards to stroke designation, they will take you to the nearest designated stroke center, no matter what, no matter what their expertise level, because that's the new law, because you need to go to the stroke center. It doesn't mean you're going to get the best care or the best expertise, but you're going to go to a place that's designated as a national stroke center. Caveat to that, Washington has created their own designation of stroke centers. They used to be nationally accredited, something called Joint Commission, for people to know. They come and they examine you, they put you through the rigmarole, make sure you're doing everything proper and you're a high-level stroke center, and then they leave and they accredit you or don't accredit you. Washington State has taken upon itself to self-designate their own hospitals. However, this is a voluntary program. There's no consequences, and the only reward is you get to go on TV and radio and say you are an accredited stroke center. But it's not necessarily accurate, but it's definitely publishable. So the question at hand is, can you choose to go to a center? Absolutely. But you do want to get to a center fast enough. So if you're in Okanagan, you say, hey, I'm on vacation, I'm having a stroke, I saw Dr. Heide, I want to see him, take me to Dr. Heide. That might take a while. I would recommend going to the nearest center that has the ability to give you TPA. Okay? The nearest place that can give you the medication you need. Okay? My goal is to create the people with my expertise available in Okanagan County, utilizing this technology. The problem with that particular entity is, we talked about the politics of medicine, is that the people in charge of making the decisions about who and what expertise level should get out to these people are the people with the money. And people with the money don't necessarily make the best decisions for you. They make the best decisions for them and their pocketbook. And so a lot of these centers, I won't name them, but you can obviously see who's around, Seattle, Tacoma, they're making the decisions where you go and who you see based on what they can make in terms of money. And so they're the ones going out to these rural community hospitals and saying, we have the best care. Not true. You're going to see people who may or may not have expertise in stroke. But the center had a lot of money. They had a lot of pull with that rural hospital. So guess what? We're going to sign them up, and now they're part of our center. That's a problem. So my recommendation is why I give these talks and why I really appreciate the kind of venue is to inform people. Ask the questions up front before you have a problem. Because once you ask the problems after the problem, you do not have a choice. Okay? To go along that point, just to talk a little bit about medical care in general, what's new and old, there's something called bundling. Everybody's kind of concerned about what's happening around the corner with regards to their health care. Anybody heard about bundling? It sounds cozy, doesn't it? Bundled up. Or it's kind of like, I'm all bundled up, right? So the reality is, down around the corners, everybody's trying to save as much money as possible. So what places are going to be trying to make the most money? Hospitals. Everybody wants, hospitals should be the place you go to get care, right? Not in my mind. Hospitals are the place to make sure you don't die. Afterwards, you go get care. Problem is the hospitals are having money, and the problem is the government is buying into this. And there's something called bundling. If anyone hasn't heard about this, bundling is where you're going to show up to the hospital, seen in the ER or admitted. The hospital is going to get paid all the money. Then the doctors you see afterwards better work for that hospital system. Otherwise, they'll be begging like little handouts saying, can I get paid, please, for that patient? Because all the money goes to the hospital for the entire care, for that entire event, start to finish, however long that may take. And so pretty soon, when you show up to a hospital for care, you will not necessarily have a choice where you get to go. Because or expertise you want to see will not be part of that bundling process, and they won't get paid, and they can't see you. What's new, what's old? Something called pre-authorization. Does anyone know what pre-authorization means? You see your physician. Say you're on an antihypertensive or a cholesterol medication, and he goes, oh yeah, you got swelling in your leg, so we got to check that, and I can't pee, so I got to check my bladder. So there you go. You got 3 medications, you got 2 procedures, and you got a follow-up care. That's 6 things. Pre-authorization means the physician's office you just saw that wants to get all those things done has to call 6 different times, most likely to 6 different people, spending a minimum of 10 minutes, most likely an hour on the phone for each event to get it what's called pre-authorized. What's even better, when I'm seeing a patient in clinic and I order a medication, I hate medications, okay? Just bottom line, I think people can do better with less, especially if they take care of themselves. But sometimes people do need medications to bridge them until they're healthy. So I want this person on a blood pressure medication. So I write out blood pressure medication, whatever it may be. I send it to him, I give it to him, I give him to the pharmacy. 2 days later, I get a fax back saying, we need pre-authorization for this. So I have to have one of my staff members call up a phone message, leave a message, and hope they'll call back. Once they call back, then they say, okay, we'll send you a letter getting approval for that particular process. And then they send me a letter saying, Are you sure you want to put this person on this medication? Yes. How many days have it taken to get this person? This is where things are going. You can imagine, right? This is what it's like. The problem is you never see that, right? So what happens? This is actually from one of their sites. I had to bring this up. This is fantastic. How does, this is actually from an insurance company's site to get pre-approval for one medication. How does the drug prior authorization work? If you need a prescription drug that currently is not covered by your outpatient prescription drug benefit, your physician or an authorized member of his or her staff may obtain coverage approval by requesting prior authorization. If the drug is not listed, it is non-formulary. The problem is they also mention here that most of their drugs that are formulary may not be formulary. And by the way, it may change next week. Some drugs are listed on this formulary may also require prior authorization. So even something approved by their approval process needs prior authorization. This is fantastic. So what do we have here? So a formulary drug has failed. So prior authorization request to be approved, a doctor must provide medical evidence that a formulary drug has failed in an effective treatment for you, or you have experienced an adverse effect from a formulary drug. Basically, when I write a prescription for a drug, their answer for what's an adverse event that allows you to change to the drug I requested, adverse effect is defined by death or otherwise not adverse. All right, here's another one. All right, or as the patient, I can begin the process to request prior authorization, calling this number. May also request prior authorization by email by clicking here. In addition, your contact can call us to get prior authorization on your behalf. Days and times subject to change without warning. Okay? Not only that, how long does this review process take? With all these things, it could take anywhere from 2 to 5 working days for each call. And it says more than 90% of the fax prior authorization requests are completed within 2 working days. But the problem is, you're one of the 10%, and your call we actually don't have phones during that time, and we only accept faxes when yours is broken. How do I check the status of my prior authorization? Well, here's the problem. You can call member services if you have an issue. So here's the issue. Please repeatedly call your doctor's office because it's obviously their fault it's taking so long. Isn't that wonderful? Now you can see the problem. This is where it's going. And now what is the benefit of doing this? Other than just annoying you and they laugh behind the scenes at their parties. They save money doing this. How long does it take to get this approval? It's the concept is waiting till you die to get approval, right? This is their concept. The longer it takes, the more likely is you're going to give up or get too sick to actually get care. So what's new? Evidence-based medicine. What's old? Thinking. Oh, I'm really going to tick off some people now. What do I mean by this? Having a nice little flow chart, right? Flow chart taken care of. You have this problem, flow charts. We don't need people who think anymore. We just have a flow chart. Well, what's the problem with evidence-based medicine? Does anyone know what that means? Evidence-based medicine basically means if you have something that's proven, we will, number 1, test for it, and number 2, treat for it. Provide treatments and therapies based on what is proven. What's proven? Next. Living, eating, breathing, paying taxes, and dying. That's what's covered. Everything else is not evidence-based medicine. Keep going. Depends on how you define proof. So what's proven? What's proof? Next one, please. Proof is a statistical benefit. Now, who gains from statistical benefits? The companies that make these drugs. So they want to make sure these drugs get approved. And how do you get approved? You can make a very select patient population that they can actually recover from to get benefit so they can put it on market and make the money. The problem is the vast majority of you people do not fall within who's proven. So who gives us the proof? Keep going. That's exactly that. The drug companies and device manufacturers. Next one, please. Provide narrow selection criteria. What does that mean? You do not fall within this. Okay? If you show up to a hospital, if you don't have somebody who can think, you don't fall on that criteria. You don't fall on that little flow sheet. You better have someone who can think outside that little evidence-based medicine box. Otherwise, you could be in trouble. And by the way, if you don't fall within that box in the next couple years, you're not going to get treatment. So very few people are going to get treatment because there's going to be very few things that are proven. And then reimbursement will actually be based on evidence medicine. So interpretation, nothing is proven and less will be covered. That's the bottom line. Next one, please. So that's my little cookie cutter. You're not cookie cutters. people, are you? You're not the same cookie, are you? Well, the drug companies think you are.
Doc, I'm following your logic on one hand, but on the other hand, as someone who just recently went to the doctor and the doctor's got me doing like a 7 test just in case, I also see a waste there. So where is the offset between taking tests because they may have a meaning or doing tests just because we're afraid of a malpractice suit?
Right. That's a very good point, and actually that's definitely a discussion point, because here's the issue, is that a person goes into or sees their physician and they have some neck pain, right? A person comes into my office and they have neck pain. Now, I think it's just musculoskeletal. I think physical therapy would be perfectly appropriate, maybe massage therapy. But what if it's a myelopathy, right? What if it's a pinched spinal cord and now they're paralyzed tomorrow? Am I going to get sued? Absolutely. So the problem is the medical legal in the scary episode in terms of what do you do next? The problem with that logic going forward is you would think, okay, so we're worried about cost, so it's better to do less, so we're going to do less. The problem is the physician's still not covered under that philosophy. Under the evidence-based medicine, doctors are only allowed to do what's covered and evidence-based. But it doesn't cover them if there's a problem. So say I want to do a cervical spine MRI on that patient with the neck pain, and I send in the pre-authorization to do the MRI, and they don't approve it, and they get paralyzed the next day, guess who gets sued? Me. Even though I wanted to do the MRI, it's still my fault I couldn't do the MRI. So they're still not covered under this new model. So it's not structured properly to save money. It's just structured to actually make the physician liable for things he can't do that he wants to do or she wants to do.
As a business person, what I think is they have to incorporate fixed cost to material cost and reduce the expenses. Because what they're trying to do now is spread the expense based upon who's being insured or not. And that just basically fattens the whole system and makes those logic out the window.
Correct. And so instead of trying to go forth and say we want to give all of our citizens a good care, a good level of care, and we want to have our citizens have access to the highest level of care, instead we're going to restrict care, make sure that these people who don't buy into the system and do exactly what we want with the system, it doesn't work for the big hospital systems or group health or whatever, we're not going to allow you to get that care. So we're going to back off. So instead of providing more, they're providing much less. So from a business standpoint, as I am a business owner, there's 2 ways of approaching this. The customer care model, which I try to adhere to, is the better service I provide, the better diagnoses, the better outcome, the happier you are, the better quality of life, you're going to tell your friend, I get more patients. The other business model I can approach, which it just doesn't work for me, but actually is working great for these big hospital systems, is less. Cut costs, cut care, cut services, cut personnel. Try to get down to the bare bones, provide less, and get the maximum reimbursement out of what we can do. And so that's the model that we're dealing with. And so my feeling is there's going to be a 2-tiered system of care pretty soon in our healthcare system. There's going to be the hospital level of care where you show up, you jump on that assembly line, and they kind of bust you over, make sure you're not radioactive, and then you come out the other side and you go home. And then there's going to be a cash-only system that people can pay for where they're going to go and actually get cared for.
I follow your logic because it's almost like we're being forced into either going into a system recognizing that there's going to be unnecessary care and a question about what it would cost us, or we go into a concierge care where someone charges a flat rate and we may or may not use the maximum care, but when we need it, it's there. And that's a kind of a different mindset of the 2-tier system you just brought up.
Yes. The second slide I brought up there, Northwest Neurological and Neurovascular Services, that's insurance care. The second, VIP Vascular, is concierge care. We are going there. You're going to have all the good physicians going to the concierge care because that's the only way they're going to provide the level of service that they believe in. Short of that, the insurance companies are going to cut costs, cut services everywhere they possibly can. Now, statistically, you're going to do fine. That's what they're basing this on. Statistically, if you live your life, you will do fine. The problem is some people won't do fine, but that's okay because statistically you're going to be okay. Evidence-based medicine. Evidence-based medicine says statistically when a human is born, they'll do fine to a certain point, and then you're done. Why do anything in between there? Because the outcomes are going to be the same. The problem is they don't define outcomes. Outcomes is life, not quality of life. So if you're talking about quality of services, you have a person who shows up, gets treatment, or doesn't get treatment. The outcome for one person is in a coma. They're still alive. The outcome for the other person who actually found it and got treated is actually skiing and skydiving and all this kind of things. The outcome is exactly the same. 2 people, 2 lives. They're both living. Quality of life completely and utterly different. But that's not a concern to them. I have proof of this. 2 studies, one in England, one in the United States. The insurance companies and government already knew this. But this is what they found. If you live longer with a disease, okay, if you live healthier, longer, without disease, you actually tax the insurance company and healthcare system longer than if you have a disease and die earlier. So you talk about conspiracy trying to kill you off. The reason they know about this kind of stuff is because your productive years, right, you're going to be healthy statistically. No matter if you don't get any health care whatsoever, statistically, you will make it through your working atmosphere without any difficulties. After you enter into your life where you're not working anymore, you're no longer productive. You're a tax on the system. It's better if you go away. That's kind of where the death panels came in. It's not so far off in terms of where we're heading. So you're actually correct with regards to the business model. There's 2 ways to go. Yes.
Excuse me if I'm in the minority, and if so, the crowd can tell me. I came to this event because the topic was stroke care, toys and treatment of stroke care.
Yes.
And I am here with somebody whose wife has just had a stroke. We came to find out more information about that. I personally feel that you have digressed way off into a political discussion of what is appropriate. That's not why I'm here.
Absolutely.
Anyone else?
So let's move on.
Please.
Okay. Thank you very much. But this is new. This is what's in stroke care. So you're talking about providing services. This isn't so far digressed. Because this is what you're going to get when you're talking about stroke care. You're not going to get what you want. You're not going to get the level of services that are provided. Because look, that little device I handed out the room, right? That costs $20,000 to get that service. If that's not reimbursed because it's not evidence-based, you're not going to have access to it. That's political, but that's also reality. And that's also absolutely about new care in stroke. That you're not going to have access to these cool toys and cool treatments because they're not covered, because they're not evidence-based. So it's not so far digression. So we're not cookie cutters. So what else is new with regards to how you're going to get care? Accountable care organizations, medical homes. Now, medical home sounds really cozy, right? So you're going to go in and get your care at the hospital, and you're going to go sit down in the chair by the fireplace, and you're going to be really cozy. Problem is, this is what you're going to see. Wouldn't invite that over, but we want to go back to the coziness, and you invite those over for Thanksgiving dinner. Medical homes are not as cozy as they're made out to be. So medical homes, what is that? So when you're talking about having a stroke, and you're going into the hospital, you're going to go to a center that's called a medical home, and you're going to be provided care within that medical home, and you're not going to be able to leave. This is not just a home, this is a prison. You're supposed to go to this hospital, get care from beginning to end, just like the bundling. So if you have a stroke, you may not be able to get provided this fancy new stuff that I was saying, the transcranial magnetic stimulation, the stenting, the capture devices. All of this kind of stuff may not be available to you because of this new device or because of this new system. So here's the mergers I'm talking about with regards to limitation.
It seems to me like the bottom line of the evidence-based system, though, is that the pharmaceutical companies come out last. But they're not coming out last now. I mean, in other words, they're not doing a lot of testing. They're not doing a lot of prescribing medicines for people as a result of those tests. So therefore, I would think that they would be fighting that kind of thing tooth and nail.
In terms of fighting the evidence-based medicine, yes, and they are. The problem is they get funded, so they're finding new funding mechanisms, right? So now they're going directly to the consumer, or they're going to India, they're going to China, they're going to people who are paying them to do these studies to get them approved, and then they come back over here and try to sell it to the government and get it paid for. So basically that's the new system. It's no longer testing within the United States. They're going outside the system to get paid to come back. So yeah, they are fighting this, absolutely.
Do you consider the group in Tacoma, the radiologist interventionists, and they were on your right side of your chart when you said who would you choose if you had a stroke. Do you consider them a competitor, or do you consider them somebody that you would reference?
I lease a space in their office.
I beg your pardon?
I lease a space in their office. I think they're some of the best interventionalists I've ever met in this country, if not the world.
I do too.
I've trained in Boston, where they trained a lot of people, and I got to tell you, these people down here, Dr. Cott, Dr. Dohara, and Dr. Wong, are absolutely incredible, and I hooked up with them because I thought that we could make a great team and bring stroke care down here to Pierce County.
When people have strokes and you hear that a side of their body is paralyzed, does that tend to be on one side or the other?
You're talking about what side? I can't see where you are. You're talking about the brain.
If someone's to have a stroke,
yes.
Do people always have it on the right side, always have it on the left side?
Very good point. I try to be reasonable with regards to my understanding of how people conceive stroke or perceive strokes. And you're right. This is not the only you're not the only person who's asked that question. It's very true. Is that people have this conception that if you have a stroke, it's going to be on one side versus the other. Technically, that could be true because sometimes your anatomy is not the same, right? If you look in a mirror, right, those little fancy mirrors, and you look at yourself and you split the screen, you don't look the same if you take the same half of your face and put it on the other side. You look like two different people. Same thing. One artery may be larger. You have different channels going to different parts of the brain. So in certain people, yes, there's going to be a tendency to go one side or the other, but it's not left or right. It's actually individualistic. And some people who have good channels on both sides, it's random. And so it's not necessarily one side or the other you have a stroke. Basically, think of it as plumbing. Wherever your plumbing goes, that's where you could have a stroke.
Does the situation where someone has tongue or something is swollen and they're not able to swallow, is that something that tends to be temporary or that tends to be long-term?
That's a good question. In fact, when people have difficulties swallowing or speaking on the initial part of the stroke, it's often going to get worse before it gets better. Now, will it get better? Oftentimes, because you can actually compensate quite well. A lot of the things in your face in midline, which includes swallowing and things of that nature, you can actually have a stroke on one side and get better after the sides get better. But if you have a stroke on one side that caused problems speaking or swallowing, and then you have a stroke on the exact opposite side, you can actually permanently lose your ability to swallow. So in terms of having the stroke, you can get worse before you get better, but you often get better because your brain helps rewire itself. But if you have a humongous stroke that just takes out your entire ability to speak or swallow, this may never come back. And so oftentimes people have to, I don't know if you've had friends or family or loved ones that you've known that have had to have what's called a PEG tube placed in their stomach to help them swallow. That sometimes is an outcome. But believe it or not, the PEG tubes aren't necessarily permanent either. I have several patients who can't swallow for a week or two. We can't keep the thing in their nose for very long, but eventually they do get better and we can pull that tube and they start swallowing again.
What are your thoughts about using mild hyperbaric oxygen therapy for post-stroke?
I just put it in my clinic. Here's the theory. The theory is that you have what's called a penumbra. You have a stroke. It damages your tissue. Around the tissue there is some damaged area that didn't quite get enough oxygen or isn't quite getting enough oxygen. The theory is if you get too much oxygen during the acute phase, the free radicals that are formed can actually damage the tissue. So you don't want to do it too early, but in fact, if you're not getting enough blood flow, what could help? More oxygen, more blood. So theory is, I'm going to try it. I'm going to see if it works.
You've presented a lot of material tonight. And prior to my coming here, our family basically has very little information on strokes. To a certain extent, my head is spinning, and as much as there's so much stuff that I wonder, what's the first step? And so that's my question, very simplistic. I come in, I listen, I hear what you're saying. I'm motivated to do something about my awareness of my own condition. What would you say that I should do tomorrow? I use tomorrow in a little broader sense, a week, 2 weeks, a month, whatever. And I'd like to be a messenger of what I've learned tonight to my family. What should I do?
So that's multi-pronged, but what should you do? There's the what should you do to educate yourself? The American Stroke Association has an excellent website that actually has good patient care information, and the same as the National Stroke Association. That's a good way to start with the education standpoint in terms of where do you start about educating yourself just in general about stroke. What's the reality of the situation? If people were to take care of themselves, I would be out of business, honestly. Sleeping properly, good stage 4 sleep. What the heck does stage 4 sleep mean? Stage 4 sleep is where you repair. You do not repair during the day. You don't heal during the day. You cut yourself. You heal best with your skin while you're sleeping in stage 4 sleep. How do you get best stage 4 sleep? You stay less stressed. How do you stay less stressed? You eat right, you exercise. You make sure you put yourself in that stage 4 sleep. If you don't drink caffeine, guess what? Caffeine disrupts stage 4 sleep. This much caffeine lasts 2 weeks in the body. You've disrupted your sleep for 2 weeks by drinking the caffeine you did 2 weeks ago. So people don't realize this kind of stuff. You take good care of yourself. You exercise, you eat right, you sleep. Put me out of business. Okay? I got other things I can do. I built koi ponds before I went to medical school. Okay? I don't mind you putting me out of business. Okay? I can take care of myself. There are a lot of studies that people do to justify their debauchery. Right? We like our bad habits. So we better find a study that proves, right? Evidence-based medicine. Let's prove that alcohol's good, smoking's good, cocaine's good, whatever. Let's do a study that shows all this stuff is great for us. Seriously. Alcohol, there's lots of studies. We like to drink alcohol. I don't drink alcohol personally, but people like to drink alcohol. I don't hold it against them. But everything in moderation, well, that's kind of an overused term, but it's a reality with regards to alcohol. The dilatory mechanisms open up your blood vessels around clots. Yeah, it's good. When does that usually happen? That usually happens around half a glass or to 1 glass a day. Do you need 2, 4, 6? No, but I'm sure there's a study out there that shows 6 is great for that kind of stuff. Okay? So basically the answer is there's some things we do to ourselves that we just justify as saying that's beneficial when there's so many other things that can be beneficial. We're talking about the tannins, the stanols, the antioxidants. I drink grape juice. I'll bet you I can create a study that shows that's better, just as good as antioxidant and vasodilatory as any alcohol. And I'm going to get shot right here in the pub. But it's not going to necessarily hurt you in moderation with regards to that. Same thing with caffeine or anything. The problem with alcohol at night, people use it to kind of help them transition into sleep. The problem with that is they don't understand is that the alcohol depresses it, but then it actually excites you past the baseline when you went to sleep. So you're getting worse sleep when you use the alcohol as an agent to get yourself to sleep. Same thing with the TVs and computer screens. People fall asleep to TV. You're actually activating the brain when you're watching that right before sleep, so you get poor sleep. So what I'm saying is people are doing this and not even realizing it. They're reading the Kindle. That's an activator. You sit in bed, you turn it off, you're not getting good sleep. So get good sleep, eat well, exercise. I truly will be out of business.
I got one more simple question about symptoms. If you're seeing flashing lights or a half moon circle and something crazy like that, are those symptoms of TIAs?
Thank you for ending the talk on that particular conversation. Anything can be a TIA. I've learned my lesson. I've been doing this for a couple decades, and I got to tell you, anything can be a TIA. A headache, vision changes, double vision, speech difficulties, numbness in your thumb. Anything can be a TIA, and nothing can be a TIA. TIA is this garbage basket we throw something into because we don't know what it is, but it could be a TIA. Absolutely. So these crescent moons, visual changes, absolutely could be a blocked artery. Because you're talking about anything that can cause a neurological symptom has an artery that goes to it. That artery can be blocked, just like any plumbing can. So TIA can be actually anything at all.